Okay, doctor, can be start.
First of all, I would like to tell everyone hello, and I hope you are in the best of conditions and everything is up to your entire satisfaction. The topic today is basics of total hip arthroplasty. And most of the material is obtained from textbooks. If you go to textbooks, you will find them. The whole purpose of this lecture is to train the resident and to have knowledge and basics in total hip arthroplasties. And this would include today only the primary hip arthroplasty. Total hip arthroplasty aims to return joint function and improve joint stability for patients. If surgeons do not account for the unique biomechanics, you have to respect the biomechanics of each patient, outcomes can be bad. It can be negatively impacted. What could one end with? He would end up having a leg length discrepancy, a patient with a poor gait and dysfunction, with impingement, a rapid repair, a rapid wear of all the contents of the prosthesis, and loosening. And these are all issues that may arise. So you need to respect the biomechanics to have a good result. Accurate positioning. The acetabulum cup is one element of a total hip arthroplasty that can alleviate many of these concerns. There are 5 aspects of cup positioning that influence the success of total hip arthroplasty. And these include medialization, meaning that the cup should be flat with the inner surface, that you have reamed and properly reamed in accordance with your preoperative planning. The depth, the height, and the angular position of the cup is very important, together with the pelvic tilt. So, preoperative planning includes physical examination, taking a proper history. Don't forget about the proper history. See and know about the comorbidities of your patients. Many of your patients are elderly. See if they can tolerate the procedure. There's nothing worse than having a patient die during the procedure. You should have a full radiographic workup and templating. While taking the X-ray, you should have precise radiographic positioning and magnification and know about it. This is paramount. A standardization pelvic radiograph is obtained with the X-ray source located 1 meter from the patient. Let's be honest, how many of us do these x-rays, resulting in magnification that approximates 20%? The hips should be internally rotated 10 to 15 degrees. How many technicians follow these principles? Templating allows the prediction of the femoral and acetabula implant sizes in 90% of the cases. Any patient considered a candidate for total hip arthroplasty should have already undergone an earnest attempt at non-operative management. This typically includes the use of assistive devices, oral non-steroidal medications, acetaminophen, and activity modifications. They should have tried all these prior to say that I give up and I want the total hip done. It is important to advise patients, however, that non-operative treatment is not without risk. Think of it. Why? The chronic use of non-steroidal anti-inflammatory medications has been shown in numerous studies to cause gastrointestinal, cardiac, renal, and hepatic complications. Don't forget these. That's why you need to work up your patients very well before doing a total hip arthroplasty on him or her. Patients using oral pain medications for longer than 3 months should undergo routine hepatic and renal screening tests under the supervision of a primary care physician. Keep this in mind. The primary indication for a total hip arthroplasty in a patient with end-stage arthropathy is pain, pain, and pain. But not all the pains are coming from the hip. You should be aware of this. Pain can come from the spine. Many a patient was operated on the hip and had his pain coming from the spine. Keep this in mind. With survivorship of contemporary total hip arthroplasty components estimated to approach 20 years, those patients with greater than 20 years life expectancy should be counseled regarding the likelihood of the need for future surgery. Because when you have wearing of the prosthesis, you have to replace it. Nowadays, we're doing it more and more in the younger patients. We should explain to the patient that this operation would last for so much and so much years, and that after that period, most probably you will need further revision surgery. It is important for the surgeon to remember that the definition of both pain and limitation of physical activity may differ from patient to patient, depending on the baseline condition. Important factors to be considered in the decision to recommend or undergo total hip arthroplasty are the patient age, the diagnosis, and the medical comorbidities. Think of these 3 conditions. The age, how old is he? What kind of prosthesis do you want to use? Explain to him how long it may last with him. and let him know that he's most probably going to need revision surgery after so many years. The diagnosis. Each diagnosis will need a different type of prosthesis or different type of materials. If you get a patient with degenerative arthritis and him having a protrusio acetabuli, you would need a different approach to the management. In addition, you should be very aware of the medical comorbidities of the patient. What about the age? The patient and surgeon must recognize that current data describing the longevity of total hip arthroplasty are largely drawn from retrospective, non-blinded cohort reviews. It may be gleaned from this limited evidence, however, that excellent long-term pain relief can be obtained in low-demand patients up to 20 years or more. Why? Because they're not moving around. They're not active. They're not carrying objects, etc. This would last. And it would last most probably, if well done, 20 years or more. On the contrary, patients with greater than 20 years, life expectancy can anticipate the high likelihood of a need for future revision surgery. For patients over the age of 65, the need for revision surgery due to wear and aseptic loosening is less likely, and the indication for surgery is typically more straightforward. So it is much easier to indicate or to tell your patient that you need the total hip arthroplasty depending on how old he is. If he's over 65, it is easier because you know of the result, what it would be most likely if it is well done. The more complex scenario for the surgeon is presented by the patient between 30 to 60 years of age with a painful hip that limits daily activities. In this group, and in even younger patients, the need for a concerted attempt at non-operative treatment is essential. I would hate to see a patient 30 years of age with a total hip arthroplasty. I would advise him and his family that it would be best to try a non-operative treatment period. If we lose hope, then a total hip will be indicated. It is likely that patients in this age category will require at least one revision procedure in the future years, and this should be discussed preoperatively. I repeat, preoperatively. It is miserable when a young man comes to you having had a total hip, he has complications, and it's not lasting for long, and he tells you, hey, doc, why didn't you warn me that this would be the case? The more active the patient, the least or the less the durability of the prosthesis. I always tell my patients, if you treat your hip prosthesis, like if you buy a new car and you treat it, and you're always treating it well, it would last you for a very long time. Otherwise, it won't. It should be explained that activity modifications, including the avoidance of repetitive high-impact exercises, will protect both the implant fixation and bearing surface after a total hip arthroplasty. Keep this in mind. You should warn your patients Patients unwilling to modify their activities accordingly are less than ideal candidates. Send them to your enemies or your friends if they are insisting to have a total hip, because these are the patients that disappoint you. In the short term following total hip arthroplasty, the main reasons for revision continue to be infection, instability, and aseptic loosening. In the long term, the most common mode of failure is wear of the bearing surface, resulting in osteolytic lesions and catastrophic loosening of the implant. As a result, attempts have been made over recent years to improve the wear characteristics of the bearing surfaces, particularly for younger, high-demand patients. Growing data exists to support the contention that newer wearing designs will outlast their older counterparts. Again, it must be recognized that these retrospective reviews provide little evidence of implant survivorship beyond 15 years. They give us a lot of information on the early survival, but none give us sufficient information after 15 years. While laboratory data would suggest the absence of clinically significant wear in metal on metal, ceramic on ceramic, and metal on highly cross-linked polyethylene bearing surfaces, surgeons have previously witnessed the disastrous, I repeat, the disastrous results when in vitro data failed to translate in vivo, meaning that in vitro you see excellent results, but when you insert them in the individual, the vivo presentation will be very different. It is crucial that the surgeon remains realistic with younger, higher demand patients and explains the limitations in accurately predicting implant survivorship. Let us give you an example. On the left-hand side, you have an anterior-posterior radiograph of the right total hip arthroplasty, and this was taken 6 weeks post-operatively. In the middle, you have the AP radiograph of the same patient taken 20 years later. You should note the large area of osteolysis superior to the well-fixed acetabula component. Now in C, you have an anterior-posterior radiograph of the same patient 6 weeks after headliner exchange, retention of the well-fixed acetabular shell and femoral stem, and bone grafting of the osteolytic lesions. There are 2 lesions, you notice, one in the superior aspect of the acetabulum, and the other is just inferior to the collar. Now, later on, you will see that there are some arguments against the collar, and we will be discussing them. Many authors have demonstrated excellent long-term results from total hip arthroplasty, even in extremely young patients. In a retrospective review of total hip arthroplasties in patients with early onset juvenile rheumatoid arthritis, mean age 17.8 years. Kitsolis et al. Demonstrated excellent long-term results. But these patients have pain. They don't move around much. They're not active. They last a longer period. But if you get a young patient who has simply degenerative arthritis following a fracture, well, this patient is active, and therefore his hip won't last as long as in rheumatoid patients. With over 20-year follow-up, only one acetabulum component was revised due to aseptic loosening. The authors advise that surgery in this age population is technically more difficult and should be performed in specialized centers. The diagnosis. The most common diagnosis for which total hip arthroplasty is indicated is osteoarthritis. The results of total hip arthroplasty in patients with radiographic signs of severe degenerative joint disease coupled with anterior thigh or groin pain are quite reliable. Less commonly, the surgeon will encounter patients with radiographic findings of severe hip degeneration and the absence of characteristic hip pain or patients with pain out of proportion to the radiographic findings. It is important to search for other sources of pain. I mentioned it before, and I mention it again. Pain is not only the result of degenerative arthritis of the hip. It can be referred from other sources, and you might be confused with the diagnosis. And if the pain has been present for more than 3 to 6 weeks, it would be prudent to obtain further imaging with magnetic resonance imaging, etc., to evaluate the pain. In patients with osteoarthritis of the hip, other joints are typically affected as well, in addition to long-standing gait and posture disorders. Lumbosacral arthroplasty is quite common among these patients, and pain radiating below the knee to the foot is more likely to be attributable to disease within the spine than the hip. I received recently a patient complaining of back pain, and he had pain radiating to his knee. He saw a neurosurgeon. He told him, you have a huge disc with spinal stenosis between L3 and L4. He operated him and removed the disc. The patient, from the time of the operation till the very present that he came to see me, had the same pain with the same radiation, and the surgeon at that time said, why didn't I take an x-ray of the hip? And it turned out that he had severe degenerative arthritis of the hip, and all his pain was from the hip. So you have to be aware of this. Total hip arthroplasty will not likely relieve pain radiating from the spine. And while the patient's gait may improve post-operatively, there is a possibility of worsening pain from other joints due to increased mobility. You have to keep this in mind. You have to warn the patient. If you know that there are other joints that are involved, you should be aware of what could happen. When the patient is operated for his hip, he's more active and he moves around more. And therefore, he could begin to have pain in other joints. This is a possibility you have to keep in mind. Patients with end-stage arthrosis, secondary to inflammatory arthropathy, are also excellent candidates for total hip arthroplasty. Preoperative evaluation of patients with rheumatoid arthritis should include routinely, and I beg and urge you to do so, patients who have inflammatory disease are known to have involvement of the spine, especially the cervical spine, especially at the level of C1, C2. The anesthesiologist might not be aware of this. It is your job to know that you should examine the cervical spine for ranges of motion, and if necessary, take radiographs to rule out any subluxation at the level of C1, C2, and inflammation of the joint. Because while turning the patient around or even intubating him, the patient can die. So keep this in mind. This would save you problems, medical legally. Large erosions and severe bone deficiencies are typical of this patient population, and preoperative templating should alert the surgeon to the need for special implants. Results in this group are encouraging even in those with early onset or juvenile rheumatoid arthritis. So I urge you, whenever you have an inflammatory condition destroying your joint and you decide he needs a total hip, investigate your patient as a whole. If necessary, consult the rheumatologist. Evaluate him from head to feet to avoid complications. Inflammatory diseases have a decreased incidence of implant loosening. Pay attention to what I'm saying. They have a decreased incidence of implant loosening and the highest rate of implant survivorship for this group. Sochart et al. Reviewed the results of 226 Shanley low-friction arthroplasties at a mean of 20 years and found the lowest incidence of implant failure in the 63 patients with rheumatoid arthritis compared to those with congenital hip dislocation and osteoarthritis. All explanations apply to this. Lack of activity, they are slow, and therefore they have no force being applied to the implant, which is significant. This increased longevity is likely due to the lower level of activity, typical of patients with severe rheumatoid arthritis. Osteonecrosis of the hip is a common cause of end-stage arthropathy. The etiology of osteonecrosis is simplified to include direct and indirect causes. The most common direct cause is trauma, resulting in decreased blood supply to the femoral head, while atraumatic osteonecrosis is most likely due to corticosteroids use or alcoholism. Keep this in mind. Treatment of the early stages of osteonecrosis may include core decompression, vascularized or non-vascularized bone grafting to support the zone which has not settled down or not fractured or not has been impacted, you can bring a fibular graft or a cortical graft and impact it in to support the zone of necrosis. This can be done in combination with a vascularized graft or a non-vascular. I have used several osteotomies, and there have been cases that have reverted to normal and did not need a total hip. Once the femoral head has collapsed, however, most authors would support the use of total hip arthroplasty as the preferred method of treatment. Mont et al. Compared the results of cementless total hip arthroplasty for patients with osteonecrosis to patients with osteoarthritis. He collected patients with osteoarthritis, patients with osteonecrosis, and he inserted a cementless prosthesis in all. Both groups of patients were relatively young. The mean age was 38 to 42 years, respectively, and both were followed for a mean of 3 years. What was the result? Good, excellent results were obtained in 94% of patients in the osteonecrosis group and in 96% of the patients in the osteoarthritis group. The authors concluded that at short-term follow-up, the results of osteonecrosis and osteoarthritis appear equivalent. The debate regarding the role of total hip arthroplasty in patients with an acute femoral neck fracture continues to evolve. The two most important predictors of outcome in this group of patients seem to be physiologic age and fracture displacement. For younger patients with non-displaced fractures, internal fixation and joint salvage remains the gold standard treatment. For elderly patients with a displaced femoral neck fracture, prosthetic replacement seems to be both cost-effective and associated with improved pain and function scores in multiple long-term studies. Literature would support the use of total hip arthroplasty in this patient population as the most durable, cost-effective treatment alternative. Hemiarthroplasty is useful in patients without evidence of acetabular wear. But concerns exist regarding the early development of groin pain following a hemiarthroplasty, like we used to do in the double mobility conditions, and of more prosthesis. There does not appear to be any difference between the use of a bipolar or unipolar hemiarthroplasty in this group. Some patients at the time of surgery, they were having a good acetabulum. Later on, you see that the head and the prosthesis gradually migrates medially, and the patient starts complaining of pain. This does not always happen, but it does happen. Total hip arthroplasty in patients with a previous history of trauma or surgery can be technically challenging. The patient's anatomy is typically abnormal. Preoperative templating and planning is particularly useful in this scenario to alert the surgeon to potential intraoperative problems and the need for special instruments to remove previously placed hardware. Ladies and gentlemen, or gentlemen alone, depending on the attendance, you should always be aware of hardware present in your patient. At times, it might be very hectic and troublesome to remove the material. Is everybody hearing? عم تسمعوني يا جماعة؟
اوكي دكتور، واضح.
واضح. اوكي. عندي هون سكرين ستوب. شو هيدا؟ ما فهمت. عندي شيء هون. Okay. This is an anterior posterior radiograph of a 60-year-old male with a history of previous proximal femoral osteotomy. In B, you have a lateral view, and in C, you have a postoperative anterior posterior radiograph of the left hip after conversion to a total hip arthroplasty and supplemental fixation with the cortical allograft strut and circlage cables. You see, at times, it won't be easy to remove the screws. At times, you might get crossed heads, or at times you get hexagonal heads. Your screwdriver might not be available. So you have to have a good preoperative planning. For patients with a history of multiple previous surgeries, or
John?
even multiple previous attempts.
دكتور جون سامعني؟
عم تسمعوا؟
بس السلايدات فريز على السلايد اللي فيه treatment of early stage of osteonecrosis.
You want me to start from there?
No, السلايد is freeze يعني وقف السلايد هذا اللي treatment of early stage of osteonecrosis.
ما فهمت. I'm not seeing you. What?
السلايد وقف او فريز، ما تحرك من السلايد اللي هو treatment of early stage osteonecrosis.
Okay. This slide. Treatment ما عم بيتحرك ابدا؟
لا.
So I'm going to have to go in again.
Okay.
Okay. Now, you're seeing the slide?
Yes.
Are you seeing the slide?
Yeah.
Now, tell me, is it changing?
Yes.
Okay. Mont et al. Compared the results of cementless total hip arthroplasty for patients with osteonecrosis to patients with osteoarthritis. As I mentioned previously, these patients are younger in age. In the study of Monty, the ages ranged between 38 and 42 years, and he had a follow-up of 3 years. A follow-up of 3 years. And what did he find? he found good to excellent results were obtained in 94% of patients in the osteonecrosis group and in 96% of patients in the osteoarthritic group. The authors concluded that at short-term follow-up, the results appeared equivalent. You see, this is contrary to what we were told before. Investigators claimed that the results of total hip in osteonecrotic patients were not as good as osteoarthritic patients. In this study, he found that they were nearly the same. The debate regarding the role of total hip arthroplasty in patients with an acute femoral neck fracture continues to evolve. The two most important predictors of outcome in this group of patients seem to be physiologic age and fracture displacement. For younger patients with non-displaced fractures, internal fixation and joint salvage remains the gold standard treatment. For elderly patients with a displaced femoral neck fracture, prosthetic replacement seems to be both cost-effective and associated with improved pain and function scores in multiple long-term studies. The literature would support the use of total hip arthroplasty in this patient population as the most durable, cost-effective treatment alternative. Now, coming to hemiarthroplasty is useful in patients without evidence of acetabular repair. But concerns, I repeat, but concerns exist regarding the early development of groin pain in these patients. There does not appear to be any difference between the use of bipolar and unipolar hemiarthroplasty in this group. Total hip arthroplasty in patients with a previous history of trauma or surgery can be technically challenging. The patient's anatomy is typically abnormal. Preoperative templating and planning is particularly useful in this scenario to alert the surgeon to potential intraoperative problems and the need for instruments to remove the previous placed hardware. And over here, as I was mentioning, this was a previous osteotomy that he had a plate on these, and now he has degenerative arthritis of the hip. You have to look into the screws, see what type of screws, to have the proper screwdriver. At times, it's very difficult to remove the screws after so many years. So you should be alert. And once you remove them, you can do your procedure as is described on the extreme right-hand side. For patients with a history of multiple previous surgeries or even multiple previous attempts at total joint arthroplasty, the Charlie pseudoarthrosis test, which I was not aware, thanks to Dr. Muhammad Rashid, who finally, through his investigation, knew what this test is. This is helpful to decide whether to proceed with a repeated attempt at salvage. The essence of the pseudoarthrosis test is to proceed with an attempt at total hip arthroplasty, and if the patient will be no worse off with a resection arthroplasty than the present condition, should be done, meaning that the total hip should be attempted. Previous hip fracture and prior hip surgery certainly confers a higher risk of perioperative complications, including dislocation and fracture. Because it can be difficult in such cases to obtain a good repair of the deficient posterior soft tissues, some authors have advocated the use of an anterior approach in these patients to reduce dislocation rates. Despite these limitations, the longevity of implants after failed internal fixation is excellent, with one study demonstrating 100% survivorship at 7-year follow-up and 87.5% survivorship at 10-year follow-up. The results of total hip arthroplasty for severe developmental dysplasia are mixed, in some series showing excellent long-term survivorship and others reporting a greater than 25% revision rate. Many patients with long-standing congenital hip dislocation are surprisingly functional and have very little pain. And this I back up in my own cases. I have done over 100 cases of Crow 4, high riding dysplasias of the hip. I've gotten the hip down to the true hip center with shortening and full control with neuromonitoring. Make sure that the sciatic nerve is functional. And I have excellent results till the very present. It is not uncommon for patients to accommodate to this hip deformity into the 5th and 6th decades. The major indication for joint replacement in this population is significant pain leading to a progressive deterioration of function. The surgeon should have an open discussion with the patient prior to surgery regarding the particular risks involved with total hip arthroplasty for severe dysplasia. If you don't have experience, don't do it. I've been called to assist several surgeons who had difficulties while doing the procedure, and I had to help them terminate the procedure. All I can say, you have to be an experienced surgeon to deal with these cases. Specifically, it should be explained that restoring the hip center of rotation may involve significant lengthening of the limb, placing the neurovascular structures at risk of injury. One of the warning points I mentioned is that I do the hip reduction to the true center following the osteotomy of the proximal end of the femur, because then the two joint muscles would be relaxed and I can do all my work and be at ease from damaging the sciatic nerve. At a later time during the surgery, I decide how much shortening I want to remove from the distal fragment and apply my plate following the insertion of the stem. The plate can be applied with circular wires and whatever screws you can apply onto the rest of the shaft of the stem. Now, I would like to stress at this point, during these cases, you will be able to rasp the proximal end, and once you remove the lens required, you'll end up having a widening of the distal fragment. So if you're going to use a regular stem, it will be loose. And to use cement in these cases, you're asking for a higher incidence of non-union. And what should you do? So we resorted to using an S-ROM prosthesis where we had two separate components to fit in tightly, and then we did the join of the two components. Well, this comes in a separate lecture, and how to do these procedures. For patients with Crow 4 deformity, when the expected limb lengthening will exceed 3 centimeters, a subtrochanteric shortening osteotomy is indicated. And this is what we do in all our Crow 4 or even Crow 3 procedures, hips. An example, on the left side, you have an anterior posterior pelvis radiograph of an otherwise healthy 46-year-old male with a history of bilateral developmental hip dysplasia. You can see that these are Crow 4. You have a pseudo acetabulum at the higher level. The patient complains of pain, not only in the hip, but in the back from the duck waddle gait that they have. And this patient had bilateral Shan's operations in the past, so as to shift the weight from the head more distally. You can see the angular deformity, which is remnant of the Shan's osteotomy of the shaft of the femur. If you look at the extreme right, you see that there is an osteotomy in the proximal femur. There was shortening, and the cup was inserted at the proper angle, and sufficient reaming was done, and the head was kept in place, and the result was good. But let me tell you one difficulty. If you look at this prosthesis, the stem, approximately the width of the femur in the metaphysis and around the greater tuberosity is wider than distally. So if you rasp these, you can apply a press fit proximally. Distally, it's quite difficult to apply a press fit. So what we did in many of our cases, we had to insert cement around the distal so as to get perfect stability. But we aimed at preventing any cement from entering the osteotomy site. And then whatever shortened component of the femur was taken, we slit in two and we applied it from both sides. Again, I tell you, this is another lecture in itself. Without the medical comorbidities, total hip arthroplasty is designed to improve patient quality of life, and as such, it should be presented to the patient as an elective procedure. In rare instances, the need for total hip arthroplasty becomes more urgent, such as in cases of rapid, progressing acetabular bone loss, which could compromise the outcome of future surgery. Let's take another example. You see here, you have a high Crow, I would say it's a Crow 1 or 2, and it's eroding the superior dome of the acetabulum. And if you look on follow-up of this patient, you see that there is more degeneration, there is more destruction after a few years. So the earlier you do it in these cases, these particular cases, it will be better. More typically, however, the decision to undergo total hip arthroplasty should be made in a controlled manner, allowing for a discussion of the particular risks and benefits to the patient. The existence of significant pre-existing medical comorbidities that I have repeatedly stated are very important. In a retrospective review of over 30,000 patients who underwent total hip arthroplasty over a period of 30 years, Parvizi, a man who we all respect, reported 90 deaths within 30 days of surgery. Mortality rates were statistically higher for patients with pre-existing cardiovascular disease and those greater than 70 years of age. Interestingly, during the last decade of the study period, there was a statistically significant decline in the mortality rates. It went down from 0.29% to 0.15%. Why? Of course, because they began to pay attention to these lousy, bad comorbidities. Dearborn et al. Reviewed the results of 2,736 primary and revision total hip arthroplasties performed over the same time period. 8 deaths, 0.3%, occurred within the first 90 days after surgery. The authors attributed half of this mortality rate to pre-existing severe cardiovascular or hepatorenal disease. Preoperative evaluation, finally, should include a thorough history, physical examination by a medical physician to determine the existence of significant medical comorbidities. So you should have a team approach to follow up these patients preoperatively and post-op. What are the contraindications to total hip arthroplasty before we go into it? The main contraindication to total hip arthroplasty is active, local, or systemic infection. We all agree about this, even the people attending. Patients with a history of previous hip infection should undergo thorough preoperative evaluation, including erythrocyte sedimentation rate, C-reactive protein, complete blood count, and if necessary, joint aspiration. If all these tests are negative, the likelihood of infection is low. However, the patient should be counseled that intraoperative findings may dictate the need for resection arthroplasty and insertion of an antibiotic spacer placement. Intraoperative biopsy in such patients may help to confirm the absence of a subacute infection. Excellent clinical results have been demonstrated in patients with a history of joint infection greater than 10 years prior to total hip arthroplasty. Active acquired immunodeficiency syndrome, AIDS, may also be considered a contraindication as the risks of infection and other medical complications may outweigh the risks of surgery. While not considered a firm contraindication to total hip arthroplasty is morbid obesity, which has been shown in numerous studies to result in higher perioperative complication rates. Number et al. Found that 36% of 1,071 total hip arthroplasties were classified as morbidly obese, especially in the United States, with a higher proportion being female. The odds ratio for infection was 4 times higher in obese patients with a body mass index of greater 35 than non-obese patients. Lubeck et al. Reviewed a cohort of 93 patients, of whom 31 were classified as being obese, with a BMI of greater than 35. Obese patients had a higher dislocation rate and had a higher risk of revision. Other studies repudiate these claims, citing technical error as the reason for higher complication rates among morbidly obese patients, but the issue remains controversial. So, out of all this discussion, which I have discussed for 1 full hour, the take-home message is total hip arthroplasty is potentially life-altering procedure that offers the advantages of reliable pain relief, improved function, increased independence, and the primary indication for total hip arthroplasty is pain and limited activity due to end-stage arthropathy refractory to non-operative treatment. With current techniques and proper indications, the vast majority of patients who choose to undergo total hip arthroplasty will experience years of lasting pain relief and improved function. Now, we come to total hip arthroplasty. I'll tell you, maybe I bored you in the previous discussion, but it's nice and important to cover this topic before going into total hip arthroplasty. The re-establishment of appropriate hip biomechanics is an objective of paramount importance in total hip arthroplasty. It is the value of preoperative X-ray review and measurement help achieve this goal. Early techniques that utilized cement on both the femoral and acetabular side allowed the surgeon to adjust the position of either component within the cement mantle and more easily compensate to achieve proper hip biomechanics. The increased popularity of cementless implants beginning in the 1980s forced a change in this practice. With cementless implants, the placement of the components was most significantly determined by the patient's native anatomy. Thus, the surgeon's ability to dictate and customize component position within the cement mantle became limited. This change made preoperative templating an even more crucial step in the planning of a cementless total hip arthroplasty and refined the preoperative planning process. Ng et al. Published enhanced radiographic techniques and templating principles that address these developments. With the advent of digital X-rays, some templating is now being done with computer software. The focus on the use of the printed radiograph and the principles of digital templating are the same. Overall, the common goals of hip reconstruction are to recreate the anatomic biomechanical axis as accurately as possible by focusing on restoring the anatomic center of rotation and femoral offset while attempting to equalize the limb length. So, you should aim at three things mainly. The center of rotation. That's number one. Then you have to think of the femoral offset. Why think of the femoral offset? Because it decreases and controls the reaction forces on the abductors. And three, you have to aim at preventing leg length inequality. So these are the points which are very important. ما في أعرف منها when you get at the end of the operation a leg length more than 2 centimeters. The patient is not going to like it. Now let's go through acetabulum template. In standard total hip arthroplasty, intraoperative acetabulum preparation is completed prior to addressing the femur. Templating appropriately begins with the acetabular side as well. The acetabular template is positioned just lateral to the lateral edge of the teardrop at 40 to 45 degree angle. Let's go through this. Ideally, the cup is covered completely by bone and should span the distance between the teardrop and the superolateral margin of the acetabulum. I would explain this on an X-ray. Wait a bit. If the acetabulum is shallow and the hip dysplastic, complete coverage will not be possible without either excessive medialization or vertical cup orientation. What we mean by medialization, you create a protrusion within the quadrilateral plate. Otherwise, you cannot get a good cup coverage in a patient with dysplasia. Or you might have to use a more vertical cup orientation, or you have to uncover a certain portion and put a graft above it. These are points which are very important. In this scenario, a portion of the acetabular component should be left uncovered. Screw fixation, as well as the use of an enhanced porous metal surface, is often elected in this scenario for increased mechanical stability. Let me tell you, cementless cups, to have ingrowns, you need proper stabilization. If it's not stable, it will not integrate. You have to pay attention to this. And so you can have a press fit, or you can have a line-to-line fixation with screw insertion. Please keep this in mind. The amount of uncovered acetabular shell in millimeters should be noted during templating, so it can be used as an intraoperative check for appropriate component orientation. Component-specific templates are used to size and select the component that best accomplishes this with minimal removal of subchondral bone. Cemented sockets require that a uniform 2 to 3 millimeter space be reserved for cement. The center of rotation is then marked through the template. Evaluation of the center of rotation is most as easily achieved if the component medial edge is just lateral to the teardrop. In this situation, the horizontal and vertical distances from the teardrop should closely approximate those of the contralateral normal hip. If a limb length discrepancy is present with affected side shorter, most common, the center of rotation planning point is moved superiorly above the templating point, the number of millimeters of the planned correction, and this point is utilized for subsequent templating. Gentlemen, even the plate, the cup itself can also create length to the offset distance. Even the cup itself can give you more length to the extremity. It's not only the reduction of the head. It's not only the offset of the femoral component. You have to keep this in mind. Also the length of the neck, of the head as you insert it, also will give you an inequality in the extremity. Normally, only a portion of the discrepancy is corrected 1/2 to 2/3, since the appropriate side often feels longer to the patient, and full correction may also lead to excessive tissue tension and contraction. Let me tell you this. Many patients who have severe degenerative arthritis with shortening of the extremity by around 2 to 3 centimeters, when we correct this shortening and the patient is awake and begins to walk, he won't be happy. Say, my leg is much longer than the opposite. This is not the case. If you measure them, they will be of equal length. And you should reassure your patient that with time, he will adjust to it. You could warn him this prior to surgery. Now, let's speak about the cup, lateralized cup. You see, if you look at the X-rays, I'm sorry this won't show it very carefully, but if you look at the X-ray over here, you see that it's just lateral to the teardrop, and it extends to this region, the superolateral portion. Now, this plastic, a portion of it will be uncovered. You have to pay attention to this. You have to compare it to both sides. And you have to keep in mind that the thickness of the cup will add further to the length. You have to keep this in mind. Don't forget this. This is shown in A and B. Lateralization of the hip center is a common phenomenon noted in many cases of degenerative osteoarthritis of the hip. At times, you have hypertrophic osteophytes in the acetabulum, which cause lateralization of the hip center of rotation. And this condition occurs most frequently in men with hypertrophic osteoarthritis. During templating, the presence of a lateralized hip center becomes apparent when 1 or 2 centimeters of reaming is found to be necessary in order to place the acetabular component in its appropriate position just lateral to the teardrop. If this crucial finding is not recognized, the acetabular component is at risk for being placed in an inappropriately lateralized position. It has to be just lateral to the teardrop. And it should be in relation to the superolateral portion of the upper acetabulum at the proper angle. This may result in incomplete bony coverage and subsequent suboptimal stability, especially in cases where a press-fit, non-cemented acetabular component is implanted without screws. In press-fit components, complete peripheral rim contact is desired in order to obtain immediate stability. So you have to pay attention. If you have a press fit, you don't need screws for stability. It's solid. But if you have a line to line and the cup is moving, it's not very stable, you have to put screws. In osseointegration depends on stability. Complete bony coverage is desirable for cemented sockets as well. Sarmiento et al. Demonstrated lower rates of acetabular component loosening were associated with higher degrees of cemented acetabular component coverage. And the more the coverage, the less the loosening. Krakalios et al. Found that increased horizontal distance from the teardrop was the most significant factor predictive of unfavorable radiographic appearance of a cemented acetabular component. And this is very true. The more the cup is away from the teardrop in the horizontal direction, will tell you that you have a poorly cemented cup, and most probably this cup will be unstable. Identifying the true anatomic location of the hip joint in these cases can be challenging and often requires a careful intraoperative examination. The most reliable landmark is the transverse acetabular ligament that marks the inferior border of the true acetabulum and the location of the teardrop. The cotyloid notch is بتطلع بالacetabular. It appears like a vertical horseshoe appearance, which is often used and can be difficult to visualize as it often is completely overgrown with cartilage and osteophytes. In these situations, careful straight medial reaming with smaller reamers to the desired depths, followed by progressively larger reamers to enlarge the periphery in the desired orientation, can be used to avoid excessive superior placement of the acetabular component. It is not necessary, desirable to ream all the way to the unicortical plate in all cases with lateralized acetabulum. Over-reaming can result in increased risk of impingement, instability, and restricted motion. In the additional potential benefit from this slight lateralization of the cup relatively increases offset and increases the abductor moment arm. Now we come to look. If you see on the left side, you see that you have superolateral migration. So you have to compensate. You have to look. First of all, in these cases, I use a lot the ligamentum teres. It leads me to the center of the cup. In addition, I look for the teardrop, and I aim for the lateral aspect of the teardrop. And I ream as much as possible as I can. I try not to penetrate the quadrilateral space, so as to create a pseudo penetration of the cup where I don't like to have, or a protrusion. If I do have it, I try to put my cup in a more horizontal position so that the load will be on the superior aspect. These are difficult situations, and it's not always the case. If you're templating, the majority of cases would be routine. But in these severe cases, you have to follow certain principles. Another hip deformity is the superlateral migration, as I spoke, which is more common in women, especially those with some degree of hip dysplasia. The shallow nature of the acetabulum and incomplete coverage of the femoral head result in concentration of forces on the superolateral joint surface. This can cause a progressive flattening and erosion of the joint, with subsequent superior migration of the hip and associated shortening of the limb. During the templating process, this set of conditions becomes most apparent when the acetabular template is placed just adjacent to the teardrop, and a significant portion of the lateral margin of the cup remains uncovered. A wide variety of surgical options can be considered during the templating phase of these cases. If there is a well-established pseudoacetabulum, some surgeons advocate a smaller component placed at higher hip center. Let me tell you this, I have tried this. I put a smaller cup at the false acetabulum. First of all, there's not enough bone to support this cup. And second of all, you have a tendency for impingement, and they have a higher incidence of dislocation. All I can tell you, honestly, I advise you, try and work at the lower level. Try and insert your cup at the true acetabulum, at the true center, and you won't have problems. Believe me. If necessary, use an oblong metal cup with insertion of the polyethylene in it. An oblong cup, which is porous coated. Okay, be very careful about this. Try not to put your cup at the false acetabulum, saying that I could not get it down. Do an osteotomy. You will be able to bring it down very easily. It will relax all tissues around the cup once you've done your osteotomy, and forget about the osteotomy. What you have done, you've relaxed the two joint muscles, and then you can do all your work. It's not that difficult. However, there are a number of potential disadvantages to the approach of putting the cup higher level. Often the amount of supporting bone in this location is relatively small, as I mentioned, in dimension, and may be inadequate to provide proper coverage and support of your implant. This approach usually requires the use of smaller components and smaller head sizes in order to accommodate for an appropriately sized polyethylene liner. This exacerbates the tendency for instability resulting from impingement on the anterior column and anterior inferior iliac spine with flexion and internal rotation, as well as on the ischium and the extension and the external rotation. So you have impingement from all sides, and therefore the dislocation rate is higher, loosening is higher, support is lousy, the bone quality is not good at that level. Superior and lateral placement of the acetabular component disrupts the native non-diseased biomechanics of the hip and increases joint reaction forces. These increased forces carry on increased risk of accelerated polyethylene wear and component loosening. In less severe cases of dysplasia, where there is some degree of superolateral migration, but no clear pseudoacetabulum, there is often inadequate bone stock present to ream in the superolateral margin, and anatomic cup placement is preferred. Templating in these cases is let me see, what do I have here, is of critical importance, as I've repeatedly mentioned, for proper preoperative planning. When planning, the surgeon must understand that greater than 10 to 20% lateral uncoverage of the acetabular component is suboptimal. There are numerous techniques available to try and achieve at least 80 to 90% coverage of the cup in these cases. Medial reaming to the subchondral plate and use of low-profile component is one strategy to achieve an appropriate level of coverage. Screws can be used to augment the fixation of the cementless components, as they will likely not have the benefits of circumferential peripheral contact in these situations. Another technique is to fix the acetabular component in a slightly less abducted position. I don't like this than usual, and use an offset liner in the superior position to compensate for this. Let me tell you this. By doing this, you're increasing the load superiorly, and you get an earlier wearing of the polyethylene cup. In the acetabular inclination, angle of greater than 50 degrees should be avoided to prevent increased edge wear and decreased stability. In this technique should be altogether avoided the hard and the hard-bearing surgery. I'll tell you this, we don't like to increase the angle, and that's it. Let me be honest. This is the experience I have obtained. If the acetabulum component still remains 20 to 30% uncovered, structural graft fixed to the pelvis can be considered. And this is great. You have to use it with bolts. Use your screws, which are fully threaded, and put a rondelle on the screw and compress the fragments just over the acetabular component. It is crucial to recognize this possibility during the template phase, as a significant amount of additional equipment may be required intraoperatively. Make use of your head. Make use of your degenerated head. Use it as a bone graft. Create a strut on the superior aspect of the acetabulum. And this works beautifully. But you should have a stable cup. So as I mentioned, I believe in putting the cup at the true hip center wherever possible. I believe that the cup should be very stable, if not by press fit, by screws that will give a line-to-line stability. And then the uncovered position, put your bone graft taken from the humeral head, insert the screws to hold it firmly in a fixed position. Okay, this is very important. If you notice over here, this is more than minus 45 degrees, and this is the ideal position. And you can see that there is somewhat an increase in the offset. Various studies have described the use of structural femoral head autograft in these cases, and they have discussed the need for additional equipment in order to properly complete the procedure. Now, in cemented components, cement augmentation of the superolateral deficiency has been described without deleterious effects on component fixation in 5 to 10-year follow-up range. A more contemporary option is use of metal augments, as I have already mentioned, and these can be porous coated, of course, and you add it to your liner. In many of these cases, especially those requiring structured grafting, significant lengthening, of course, will occur through the acetabular component. Be careful. This is in addition to bringing the head down to the true center of rotation. So you have to have neuromonitoring, and you have to have a way to tell whether you're stretching your sciatic nerve or not. And to be at ease, I usually do my osteotomy of the proximal end of the femur at the very beginning of the operation. Then I work on the acetabulum and the head. I fix the cup in the proper position and position the head on it through a trial basis. And then I decide how much shortening should I do, not to increase the tension and traction on the sciatic nerve, leading to a pullus. So keep this in mind.